So in today's class, we will be discussing about analysis and interpretation of ABG. So I am not planning to discuss today how are you going to analyze the ABG. So what I am going to concentrate today will be on majorly we will be concentrating on how to take an ABG. So method of taking an ABG. So as the objectives of the class will be to understand the normal ABG values, but today I will concentrate on method of taking ABG. We are not taking an ABG in a proper way. So we should know how to take an ABG in a correct, appropriate method. So when you are going for different exams abroad and all, there will be a station called as objective structured clinical examination. So they will be asking you to put an IV line. They will be asking you to put an arterial line or how to set up an arterial line, how to do an ABG sampling. That will be a station given to you. You cannot just go and tell I will take this and take an ABG. That is not the correct method. So for all those things, there is a structured way by which you should do a procedure. So we will be discussing what is the exact structured way by which you need to take an arterial blood gas. So that will be the idea of this session. Mostly you need to incorporate these things in your day-to-day practice also. It is not just theoretical or just for the exam. You should do these things in your practical day-to-day clinical practice also. So at the end of this ABG module, whatever we are going to take for the next 1 week, at the end of the day, you will be completing understanding the common acid-base disorder, stepwise ABG analysis, analyzing each values, what is the normal value, what is an abnormal value, and what are the common causes for this abnormal acid-base disorders. So at the end of this module, you will be learning that. But today, what is our aim of class is, how will you take an ABG? That is my agenda for the day. So before you going to the method of taking an ABG, I wanted to know what is meant by an ABG. ABG is basically a test that measures the oxygen tension, that is the PO2, carbon dioxide tension, that is the PCO2, oxygen saturation level, that is the SO2, or you can call this oxyhemoglobin status, acidity, you will know the pH of the patient, and also the bicarbonate. So basically that is all about ABG. You are getting a lot of other information, but routine and ABG means you are getting the pH, the PCO2, the PO2, the bicarbonate, and the oxyhemoglobin status. So these are the only things that you will be ideally getting in an arterial blood gas. Whatever else that you are getting is an additional information. So those additional information you might not get in all in ABG machine, but routinely these are the only indications. So every patient that comes to the ER or in the ICU doesn't need an ABG. So whenever you wanted to know that, you want to know the acid-base status, you want to know the oxygenation status, you want to know the ventilation status. That is why when you are asking for an ABG. But in our ABG, we are getting a lot of other values also. So the most importantly, what you are getting, as I told, the most important one is acid-base balance, oxygenation status, ventilation status, and also there is something called as co-oximetry. So have you ever checked in your ABG machine? There will be something called as in the ABG report like F meth HB. Have you checked? Have you seen something like this? Hemoglobin FHB, fetal hemoglobin. This is meth hemoglobin. This is fetal hemoglobin. So some ABG machines will also do a measurement called as co-oximetry. Co-oximetry means it is measuring other types of hemoglobin. You have fetal hemoglobin. When you at your birth, you will have a lot of fetal hemoglobin. As the age advances, it will become the normal hemoglobin. Similarly, there is another hemoglobin called as meth hemoglobin, which will occur as a part of sometime due to sepsis and sometime due to certain overdoses and poisoning. So if you are able to get that result also, that is called as co-oximetry. And in our ABG machine, we will be also able to get the electrolytes, lactate, and also creatinine also. So that is the additional information that we are getting. But in a routine ABG machine, what it is intended? It is intended only to measure the acid-base status, ventilation, and the oxygenation status. So if you require an ABG, why we are taking a number of ABG more in our AD? Because we are getting a lot of other information. We are getting the electrolyte also. We are getting the lactate also. We are getting the creatinine. We are getting the bilirubin. Rather than the acid-base status, we are getting some other informations also. That is the reason why we are taking, when you see a patient is quite not tachypneic, nothing, we are asking for a blood gas, venous blood gas also. We will get these informations also. That is the only reason. But routinely an ABG means just to look for the acid base status, oxygenation and ventilation status, to understand the oxygenation and the carbon dioxide level. That is the only need of an ABG. So that is what we have discussed. Now, before you going for any procedure, you should know what are the equipments that is needed for that procedure. That is mandatory. For any procedure that you practice, you should know what are the equipments that is required. So the first equipment that you need is a gloves. You need actually two pair of gloves. It is not one pair of gloves. You need to keep two pair of gloves. Suppose one tone you cannot run behind during that time. So keep always two pair of gloves. Ideally a sterile set. Even if it is non-sterile, it is okay. But ideally it should be a sterile set of gloves that you need to collect. So that is the first requirement. And apron. That is again to avoid spillage of your dress. So you can, if you have an apron, you can use that also. So that is the next thing. Then most importantly, you should know there is something called as pre-heparinized arterial blood gas syringe. So there are different types of heparinized syringe. One is pre-heparinized. Already there is an heparin inside the syringe, and some sorry, in another syringe there is no heparin. You need to collect heparin from a vial and you need to rinse that. So you will either use a pre-heparinized one or you will use a non-heparinized one. But ideally it will be a pre-heparinized one, and you should also have a bunch or a cap. Have you seen the new pre-heparinized syringe which I have got a small cap? So that is the bunch or the cap. Why you are having that? After the procedure you need to close that. Why you are closing that? So it will not have contact with the atmospheric air. So that is the most important thing. So you need to have a cap for that also. So pre-heparinized syringe. So if you are using a non-heparinized syringe and you are collecting heparin through an additional syringe, you need to make sure that there is not a single drop of heparin inside the syringe. You need to flush out the complete heparin from the syringe. If there is even a single drop of heparin, that will give a false value to your ABG. So that should not be there. So you should rinse out the heparin completely from your ABG syringe. So that is very, very important. Then you should have an arterial blood gas needle, which is a 23 kg needle, because in this pre-heparinized syringe, you don't have a needle. So you need to get an additional 23 gauge needle and alcohol wipe. You need to prepare. You can have a cotton swab with alcohol, or you can have an alcohol swab also. Whichever is available in your area, you have to use that. Gauze or a cotton wool. So after the procedure, you need to close it and you need to tape it. So you need to have a gauze or a cotton wool and a tape. That is a micropore what we use to tape for the patient. And one important thing that you see here is lidocaine. Why you want lidocaine? See, ideally all the ABG ideally you have to give a local anesthetic with lidocaine, because anyone of you have taken an ABG yourself? It is a very painful procedure. So when you are puncturing an artery, it's a very painful procedure. So what you have to do, you have to give a local anesthetic agent, lidocaine, around 1 ml around the area where you are planning to introduce your needle. So that is very important. So lidocaine you need to take. For administering lidocaine, what you need? You need a syringe also. So you need to have a 1 ml. The small insulin syringes will do. You need to take 1 ml of lidocaine and small syringe for lidocaine and a subcutaneous needle. The syringe will come up with a needle. So that is enough. A subcutaneous needle, the small syringe for lidocaine, and a sharps container where you can dispose of all your sharps. So that is the requirement for that. So next, coming to procedure in detail, what you have to do? We have to wash your hands and don PP if it is needed. So routine for just an ABG sampling, you doesn't need a level 3 PP. Maybe just a mask and gloves is more than enough. So wash your hands, wear your personal protective equipments, and introduce yourself to the patient, which you need to do. You have to tell them, see, I am Dr. Srishnan, I am working as a doctor in the ED, I want to do a procedure in you. So you have to introduce yourself and you have to recognize that you are doing at the right patient. So I have told to do for one patient and you are doing for another patient, that is not correct. So if I have given an order, do for an ABG for Mr. X, you have to confirm that he is Mr. X and you have to verify his MRD number also. So you have to confirm the patient's names and birth. That is the next thing, or MRD number. So you should have double verification. Always make sure that you will have two verification, not just the name, not just the MRD number. You have the name and MRD number. You do a double verification. That is for all these things, all blood sample, everything. You should have a double verification. And most importantly, you need to explain the procedure to the patient. You need to tell him, see, I am going to take small needle. I will be giving a small injection so that you will not have any pain while doing the procedure. And after that, I will be drawing another syringe and I will be taking few ml of blood for analysis. This is for understanding the level of oxygen and acid level in your body. You have to explain the procedure to the patient. So that is very, very important. That is the next important thing. And most importantly, you have to look for any contraindication. You have to see whether there is any contraindication for an ABG. What are the contraindications? A peripheral vascular occlusive disease. The vessels are already gone. So you cannot puncture in that artery because already there is a PVOD. When you are going to puncture, it is going to be creating more trouble to the patient. So you should not do that. And you should look if there is any surrounding cellulitis. You cannot puncture that area. You need to use another area. Another thing is that already there is an AV fistula in that hand. You cannot do an ABG sampling in that area. So these things you have to see whether there is any absolute contraindication, and there are relative contraindication that you need to see that if the patient is having coagulopathy, INR is elevated, the patient is having liver disease, platelet count is less than 50,000. These are all relative contraindication. If there is an absolute need of taking an ABG, you can take, but otherwise you should not be taking an ABG. So if it is needed only, you should be taking an ABG. So that is the relative and absolute contraindication for your blood gas. The next important thing that you need to see is that you are going to give a local anesthetic agent. You are going to give a drug. So you have to check that if the patient has got any allergy to local anesthetic agent that you are going to give is lidocaine. You can ask that I am going to administer one drug. Have you got any allergic history? The patient is saying that he has no allergic history. Then well and good. You can proceed with the procedure. Then gain consent. See, gaining consent. Consent doesn't mean that you are getting everything in writing. What you are getting a consent, if I am asking a patient that I am going to do a procedure, can I do the procedure? And the patient is saying yes, that itself is a verbal consent. So for taking an ABG, you need not take a paper and go and get it signed from the family and the bystanders or from the patient. You can take a verbal consent. But if it for an invasive procedure, you are going to put a catheter, you are going to put an arterial line, that time you can ask for a written consent. But routinely, you just need to inform the patient and gain consent from the patient that, okay, you can proceed with the procedure. So you have to take consent, and most importantly, you have to position the patient. So suppose the patient is sitting down or lying down, we have to make sure that he is comfortable. Ideally in a lying down position, that will be the best thing, and hand will be supported, and the positioning we will discuss later when we come to the procedure in detail. So the patient should be made comfortable, and also make sure that the patient doesn't have got any pain at this moment. Already the patient has come with a large chest pain. He is having a chest pain of 7/10 pain score, and you are going to do a procedure again that is going to cause pain. You need to address that pain first. You need to give some analgesic, and you need to address that pain first. So that is the first thing. Make sure that the patient doesn't have got any pain, and if he is having any pain, you give an analgesic and you settle down that pain. So that is the next step. Now, there is something called as a modified Allen's test. So, modified Allen's test is one important procedure. It is very important procedure, but it's a very easy procedure. Okay. What we are going to see here, suppose you see my hand here. Okay. So, this is my hand. So, I have the radial artery here, ulnar artery here. So, radial artery is supplying the whole hand, ulnar artery is also supplying the whole hand. We are going to puncture the radial artery. Imagine that you have punctured a radial artery and there is a hematoma formation. And as a result, the radial artery got injured and there is no blood flow to the further from the radial artery. So what usually happens? So if there is no blood flow to that area will get gangrene. But what happened in our body that there is always a collateral circulation. So there is some collateral circulation from the ulnar artery also, so that the radial arteries affected side also will be having a blood supply. So even if problem is there in the ulnar artery, the radial artery will take care. There is a problem in the radial artery, ulnar artery will take care. So that is how the normally it is. Suppose you imagine that you are going to puncture the radial artery and accidentally you didn't get the procedure and there is a large hematoma formed and radial artery is injured. For unlucky to the patient, he also has got an atherosclerosis for ulnar artery also. So as a result, ulnar artery also there is no flow. What will happen to the hand? The hand will become totally gangrenous. So we should know how is the blood supply to the hand by the ulnar artery, since we are going to puncture the radial artery. So for to understand this, we have a test called as Allen's test. It's a pretty simple test. So what you have to tell, you have to ask the patient to clench a fist. So ask a patient to clench a fist like this. Then what you have to do, using your both the hands, you just occlude radial artery, and with the other hand you occlude the ulnar artery also. So ulnar artery you occlude, radial artery also you occlude. So both the arteries are occluded. For time being I am showing it this way, but you should use it with the both the hands. So I am occluding with these two fingers. One finger I am occluding ulnar artery, with other finger I am occluding the radial artery. I am clenched my fist and I am opening it. When I am opening it, it is pale in color. So this is what you have seen. It is pale in color. Now what I want to know? I want to know how is the ulnar artery functioning. I will just release the pressure over the ulnar artery alone. So after 5 to 10 seconds, what happened? Just see what is happening to my hand. The redness has come back. So that what does that mean? I have got a good flow in the ulnar artery. Even if the radial artery is gone, I have got a very good blood supply with the ulnar artery. So that is what is called as simply called as a modified Allen's test. So what you have to do? You have to ask the patient to clench the fist, occlude the ulnar artery as well as the radial artery, and you ask the patient to open the hand. It will be pale in color. So like you see, it is pale in color, and you release the pressure over the ulnar artery and you see whether the color has come back. Usually within 5 to 15 seconds, the color will come back. The color is not coming back. That means your ulnar artery is not good. So you should not use this hand for your radial artery puncture. So if you are doing that, what will happen? There is no good collateral supply. The patient is going to have a problem with this. So you should not do that. So that is what is called as modified Allen's test. Simple thing. Ask the patient to clench a fist, apply pressure over the radial and the ulnar artery to occlude both the blood vessel. Ask the patient to open their hand, which should now appear blanched, that is the pale color. If the hand does not appear blanched, it suggests that you are not completely occluding. You have to properly occlude it. Remove the pressure from the ulnar artery while maintaining the pressure of the radial artery. You are not removing the pressure over the radial artery. If there is adequate blood supply from the ulnar artery, the normal color should return to the entire hand within 5 to 15 seconds. If the return of the color takes longer, that suggests there is a poor collateral circulation. You should not be proceeding with the arterial blood gas analysis puncturing on that hand. So that is the mere clinical idea. So you have to do it for every patient prior you are taking an ABG sampling. If the patient is conscious and oriented, if the patient is not conscious or oriented, it is very difficult. But still you can try without clenching the fist. You can occlude this and you can release it and see. Even without a clenching of fist, we can do this procedure. So for an unconscious patient also, you can try this with a little bit of modifications. So that is called as modified Allen's test. So that you have to do for every patient you are planning for an ABG analysis. Now coming to the preparation, you have to prepare. You have collected all the equipments. You have to prepare what all things is needed. Note the patient's oxygen delivery. How much the oxygen the patient is getting. Suppose he is already on 5 liters of oxygen. You have to calculate the FiO2. PO2 by FiO2 ratio. If the patient is ARDS, you want to know how much oxygen that is going inside and what is the PO2 that you are getting from the ABG. So you have to calculate the PF ratio. So for that, you should know how much oxygen the patient is presently getting. So that is very important. The next thing, that remove all the equipments from its package. So you have to remove all the equipments from its package so that it is easily accessible throughout the procedure. Attach the needle with its protective cover intact to the pre-heparinized ABG syringe. So you have to attach that ABG syringe and make sure that you are flushing out whatever heparin is there in that pre-heparinized syringe. There should not be a single drop of heparin. Even if it is a pre-heparinized syringe, there will be little amount of heparin. You need to flush it out. Positioning of the patient, again very important. It should be 20 to 30 degree extended. The wrist should not be like this. It should be it should not be like this also. It should be 20 to 30 degree like this. So that should be the position. You can keep a small pillow or a roller bandage or whatever is available. So that should be the position of the wrist. And again, it should be comfortable to the patient also. Next procedure, we have to understand where is the radial artery. We cannot just blindly go and puncture in an area. So before that, we need to palpate and see where is the radial artery. So what you have to use? Always make sure that when you are puncturing, use the patient's non-dominant hand. Suppose I am a right-handed person, use the left hand for taking an ABG sample for me. Suppose something goes wrong, my dominant hand is preserved. So that is one reason. So use the non-dominant hand. What you have to do? Assess the course of the radial artery. You know that it is below the thumb, this area. This area will be the radial arteries course. So assess the radial arteries course and palpate the radial artery. You see for the radial pulse, where exactly is the radial artery. Palpate for the radial artery pulse. And you should be, see, if I am getting a pulse here and I am also getting a pulse here, which area you will select? Most distal area. That is the area where you need to select. Because if area, this much area is affected, if you are getting only this much area will be affected. So the most distal area where you are getting pulsation should be taken for your puncture site. So that is the site where you need to go ahead for the puncturing of your ABG. And most importantly, you have to clean this area. We have not done any cleaning. So you clean it with a cotton swab and keep it dry for at least 30 seconds. Cotton swab, use an alcohol wipe and clean it for 30 seconds. Now what you have to dispose of all those area, you wash your hands again. Suppose you are not wearing a gloves. For palpation, sometimes you will not wear a gloves. So palpate, wash your hands, wear your gloves and come back to the patient. So that is the palpation step. That is the first step that you need to do. So what we are just trying to locate where exactly is the radial artery by using the palpatory method, and we are recognizing that this is the area where I need to puncture. The next step, what you have to do? You have to give your local anesthetic agent. You have taken the 1 ml of lidocaine, and where exactly you want to puncture, you give approximately 1 ml of lidocaine if the patient doesn't have got any allergy to that area, and you wait for 60 seconds so that the local anesthetic will act. So I will just come back for whatever we have discussed. We have decided, I have asked you to take an ABG. So what all things you need? You have to gather all your equipments. You have to explain the procedure to the patient. You have to make your PP, all those things. You have to position the patient properly. You have to do an Allen's test, modified Allen's test, and make sure that there is a good blood flow. And next thing what you have to do, you have to gather the equipments. You have to palpate and see where is the radial artery. And after understanding the radial artery, you give a local anesthetic agent. So I wait for 60 seconds. Clear? Now, we have not taken ABG till now. We have just given the local anesthetic agent. Now, after 60 seconds, we have to start taking the blood gas now. Now, this is again very important. So, the first step, what you have to do is that you have to remove the protective cover from the ABG needle. There will be an ABG needle protective cover. If you have not done before, you need to remove that and flush out whatever heparin is there inside the syringe. If you have not done previously, you can do it now. Otherwise, you do it right now. So, you flush whatever amount of heparin is there inside the syringe. Hold the patient's wrist extended by approximately 20 to 30 degree. We have already said 20 to 30 degree extension. Palpate the radial artery with your non-dominant hand. As I told, this is my non-dominant hand. So, I will be palpating the radial artery with the gloves on, and I have already identified the area where I need to puncture. So, with a non-dominant hand, you have to puncture and warn the patient, tell the patient that you are going to inject, you are going to insert the needle, and the most importantly, you have to hold the needle like a dart. You know the dart, this thing, darting, you know, see in the circus, and even if you can go to the mall and all, you can use those things. So just like you throw a dart, you need to hold the needle and the syringe in that way, or you holding a pen, you want to hold it, and most importantly, very importantly, you have to do it at an angle of around 30 to 45 degree. So the hand is extended like this. So when you are inserting the needle, it should be at a 30 to 45 degree angle. It should not be perpendicular like this. It should be at an angle of around 30 to 45 degree. So that is the angle by which you need to insert. So if you are on this side, you insert this way. If you are on the other side, you insert this way. Whichever, this way or this way, that's fine. But whatever be the way, it should be 30 to 45 degree. You need to insert this. So continue to advance the needle. Now you have introduced, once you are introduced, you continue to advance the needle till you see a flashback. You see a blood in the needle hub. Don't aspirate at that point of time. Do not aspirate. You will see a flashback of blood. So that is the confirmation one that you are inside the artery. Once you are inside the artery, sometimes the blood will come by itself. The blood will come by itself and the syringe will start getting filled up. Around 0.5 to 1 ml of blood is only needed. If you are not getting that adequate amount, slowly you aspirate. But only aspirate after seeing the flashback. Without seeing the flashback, don't aspirate. You will not be inside an artery. Suppose you are getting the flashback, after that you just adjust the syringe. Sometimes the blood will naturally get filled up in the syringe. If it is not happening, you slowly withdraw the plunger so that around 1 ml of blood you have collected. So after that adequate amount of blood is collected, what is the next thing you have to do? You have to withdraw the needle and you need to a cotton swab and give a firm compression. And after that, you can apply a tape and you can cover that area with a tape and make sure that that firm pressure is continued for approximately around 3 to 5 minutes. What is the next thing you have to do? Whatever amount of air is there, you need to remove that amount of air, remove the needle and dispose of in the sharp container and use the cap and close the ABG syringe and you give this to the analysis. So that is the way by which you need to do. So you need to write the patient's name and MRD, whichever name, patient name and MRD into the syringe. Carefully expel any air, attach a sticker containing patient details, continue to apply firm pressure at the puncture site for 3 to 5 minutes to reduce the risk of hematoma formation. To complete the procedure, what all things you need to do? Explain the patient that procedure is now complete. Thank the patient for their time. Dispose of your PP and equipment in the appropriate clinical waste bin. So red, yellow, whatever be the things, you have to sharp to the sharp, blood stain into the red and all those things, you need to dispose of it properly. Wash your hands. Wash your hands. Take the ABG sample to be analyzed as soon as possible. Ideally within 10 minutes. For our reason, it is very easy. Just in front of the patient, inside the ED we have, within 1 or 2 minutes, we can give the sample and document the ABG result in the patient notes. Once you get a printout, you need to document that, then you have to analyze the result. So before you start analyzing the result, you have to make sure that a brief clinical history you should be knowing. Without a clinical history, do not analyze an ABG. Without a clinical history, we will not be able to, whoever it is, you will not be able to analyze an ABG. So that is very important. Without a clinical history, don't analyze the ABG. So what we have learned today, it's a very small topic, but it is a very important topic. So how to take an ABG? So first of all, what you should need, gather all the required equipments. Make sure that why you need an ABG. 3 reasons: acid-base status, oxygenation, ventilation. Suppose there are additional parameters that you are getting, that is different. You doesn't need an A. You can take it with a V also. For oxygenation, definitely you need an A. For ventilation, you need an A. But acid-base status, a VBG also will do good. But for all other purposes, a VBG is enough. You want to know an electrolyte, lactate, all those things, a VBG is enough. Next important thing is that you have gathered all the equipments, you have explained the procedure to the patient, you have confirmed the patient's identity, you have made patient comfortable, you have confirmed that the patient doesn't have got any allergy to lidocaine, and you have checked for the contraindications, any contraindications, and you have also checked for your Allen's test, modified Allen's test, and you confirm that this patient can be taken for an ABG. Position the patient's hand, palpate and look for the radial artery. Where to look for the radial artery, I have already mentioned. And use the local anesthetic and give around 1 ml and wait for 60 seconds. What you have to do, step by step, we have demonstrated. And most importantly, what you have to see is that analyze the result with the patient's clinical condition. Don't just analyze the values. With the patient's clinical condition only, you should be analyzing. So this is your just the normal values, whatever you mentioned. So tomorrow we will be discussing in detail regarding how will you analyze an ABG. So I am giving you a clinical condition and you have to analyze that ABG, and those discussion we will continue. Okay. So I hope it is clear. Thank you.